Today is our 296th Zoom session. For last 295 days, continuously we are conducting this Zoom session. Actually, International Forum for Promoting Homeopathy is formed with the intention of promoting homeopathy all over the world. Our only aim is to unite the homeopathic doctors, homeopathic lovers, homeopathic activists together in one platform to share their ideas and views about homeopathy. So our purpose is to give awareness to the people about homeopathy and unite the homeopathic doctors all over the world. Today's our guest is Dr. Geetha. Already she joined. Welcome, Doctor. Dr. Geetha is our guest. She got 2 bachelor degree and 2 MD. She got MD in Materia Medica and MD in Homeopathy. She's the professor and superintendent of Government Homeopathic Medical College, Calicut. And she's the chief coordinator of Infertility Project and Infertility Management in Research Center Homeopathy at Government Homeopathic Medical College, Calicut. And she has been the faculty of many seminars in gynecology and especially in infertility in almost all the colleges of Kerala, Karnataka and Tamil Nadu, and has been the faculty of seminars organized by Medical Association of Government of Kerala and Karnataka related to mother and child health care program. Had been at the board of, she is the member of Board of Studies of KUSH and Kerala and Calicut Universities. Welcome, Dr. Geetha Jose. Welcome, madam. Welcome to our Zoom session. So now you can start and your time is up to 9:20. Thank you, madam.
Thank you, doctor. Welcome and good evening to one and all. Am I audible?
Yes, madam, yes.
Today my topic is homeopathic practice in gynecology. See, homeopathic practice in gynecology means, see, with homeopathy you can practice in almost all fields of medicine. All fields of medicine is possible in homeopathic practice. Especially the speciality of gynecology is that, see, usually in allopathy also, you have different specialists and most of the conditions that is seen by a physician also. See, the physician actually sees all the cases, but when it comes to gynecology, they just refer to a gynecologist because actually most of the people, they just don't interfere in gynecology and just send it off to the gynecologist. But homeopathy, so we can treat all the cases. And in gynecology, the importance is that, see, when you're treating, see, you get a number of conditions. And in these conditions, there are certain conditions which are very much complicated, which can result in complications. That is, without knowing, you can go into complications. So the first and foremost thing when you want to treat gynecological conditions is that you have to first diagnose the condition. That is the first and foremost thing. You have to diagnose the condition. Only then you'll be able to know the prognosis of the condition. That is, what will happen to them. If you know the prognosis, you can understand. That is, when you're giving the medicines, how far the case is working progressively. That is, whether the prognosis is good or bad. So if it is good, you can just wait. Otherwise, you have to immediately change your line of management. For that, you have to know the diagnosis. That is, when you know the diagnosis, you'll be knowing the pathology behind it. You'll be knowing the prognosis of the condition. So, in all cases, you have to first of all diagnose the condition. Of course, in homeopathy, just by knowing the symptoms, we can treat the condition. But when you come to gynecology, as I told you, see, there are certain dangerous areas. It will be very likely it can be put into danger. this if you are not aware about it. So I'll just go through. So in this session, I have a very short time comparatively because I'll go through only briefly about all the gynecological conditions. See, the first and foremost, gynecological means it's something related with the uterus, fallopian tubes, ovaries. Uterus means the body of the uterus and the cervix, and something with the vagina, vulva, the urethral region. See, in gynecology, the breast also is
Excuse me,
there.
madam.
That.
Excuse me,
Okay.
please. Many comments are coming. It's not clear. You can use a microphone, I think.
I'm using a microphone.
Really? Okay. In the chat box, I got four comments about it's not.
Okay, now is it audible?
Yes, audible. It's already audible,
Yeah.
but I think they need more loud.
Clear now? Is it clear now?
I think when you use the microphone, madam, there is the fan, electric fan or something is creating some disturbance here. So maybe you stop using that microphone and directly use the microphone of the laptop, then it may be better audible. I think now it is better audible. Please continue.
I remove the microphone.
Yeah.
Should I put off the fan?
I think
Maybe.
Okay, yeah, I'll do it.
maybe is
Easy. Okay, is it audible now?
yes, yes.
The clarity, what about the clarity?
Yeah, it is fine. It's fine now.
Okay, okay, then I continue. Should I repeat the whole thing which I said?
No need, madam.
No
You
need.
can.
Okay then. So when you come to the gynecological conditions, so it's something related with the uterus, the fallopian tubes, ovaries, coming downwards, the vagina, vulva, all these things. We are not going into the breast conditions and all, just this condition. See here, see when a patient comes with, see usually in gynecology, the patient will be coming with bleeding, either with bleeding or with a vaginal discharge, something like that. See, whatever it be, see, if it be a vaginal discharge itself, there are a number of conditions related to it. That is why the patient gets a vaginal discharge. When it's a bleeding, there are a number of conditions you have to go through. That is why the patient has come with the bleeding and what will be the cause of that bleeding. So you have to trace back what is the condition. So come to the diagnosis. See, when a patient complains of menorrhagia means that is there'll be the cycle will be regular, but the bleeding will be profuse. See, there are a few conditions which you can think of when a person comes with menorrhagia. See, menorrhagia, you can think of a fibroid. It can be a case of adenomyosis. That is when the body of the uterus is affected with endometriosis. We call it as adenomyosis. So it can be a case of adenomyosis. It can be a case of PID or just a hormonal variation, imbalance in hormones can lead to menorrhagia. Or usually menorrhagia, it will be just a continuous bleeding like that. It can be a case of PCOD. So any of these conditions or just endometrial hyperplasia can lead to a continuous bleeding. That is menorrhagia, cycle regular but continuous bleeding like that. But there will be slight deviations. That is in endometrial hyperplasia and all, the patient will be having a short period of amenorrhea. That is 1 or 2 months amenorrhea followed by continuous bleeding. That you can't call as menorrhagia. In menorrhagia, the cycle will be regular, but profuse bleeding will be there. Of course, in PCOD also you get this short period of amenorrhea followed by continuous bleeding. In some cases, it is usually irregular cycles, but in PCOD, the irregular cycles will lead to an appearance of bleeding. Sometimes it will last, that is, you get a protracted bleeding. Protracted means continuous bleeding like that. That is, it will be increasing and decreasing in quantity. Like that, and intermittent flow can occur. It will be just getting prolonged like that. Throughout the month, there will be bleeding. So it can occur like that. So whatever be the condition, you have to analyze each and every symptom. Then the next symptom that comes in our way is dysmenorrhea. See, dysmenorrhea, you have a simple dysmenorrhea. That is, it's very simple because there's no, there won't be any pathology. Usually without any pathology, you get a spasmodic dysmenorrhea. That is spasmodic dysmenorrhea means the patient will be having very severe pain associated with nausea, vomiting. The patient can even faint with the pain. It will be very severe, but actually when you look into the pathology, there won't be much pathology behind it. Usually there won't be, you can consider it without pathology. The only pathologies you can get are just a fibroid in the cervical region, or a polyp in the cervical region, or cicatrix formation in the cervical region. These are the only pathologies you can assess in a spasmodic dysmenorrhea. See, that usually occurs in young girls, the spasmodic dysmenorrhea. They'll be having very severe pains. So there you have to think that these are the only pathologies that can occur. That is, the reason is when the cervix, that is when the menstrual blood is squeezed past through the improperly dilated cervix, you get this pain. The pain is elicited, that is a spasmodic type of pain. It is just the spasmodic pain. So you call it a spasmodic dysmenorrhea. And the duration of pain, it will be of a short-lasting nature. Just a few hours pain. That is, it won't go beyond 12 hours, just a few hours pain. But during this pain, the pain will be very intense. That is, the patient will be almost collapsing in some cases. So that is spasmodic dysmenorrhea, but it's less dangerous because the pathology is very less. See, this pain, you can get in, which you get in young girls, it can be a congestive dysmenorrhea in some cases. See, congestive dysmenorrhea means definitely there will be a pathology behind it. And in congestive dysmenorrhea, the pain will be lasting for more than 24 hours. See, the classical pattern of congestive dysmenorrhea is that it starts a day or two before the onset of menstruation, and it will be persisting throughout the days of flow. That is, with the flow, there will be relief of pain. Relief means the intensity of pain will be getting reduced, but the pain will be there. So it will be, that is a classical picture. That is, it will be persisting throughout the days of flow. So even though there is a classical picture, it can occur in another form. That is, it can occur on the first day. That is, before, I told you, it can start a day or two before the onset. It can occur just on the first day or on the second day. Anyway, it will be persisting for more than 24 hours. When you should consider it as a congestive dysmenorrhea. So in congestive dysmenorrhea, always there will be a definite pathology behind it. And in a young girl, if she's having a congestive dysmenorrhea, you should rule out endometriosis, because see, endometriosis, the age incidence is between 35 and 40. Still, it can occur in young girls also. And nowadays, endometriosis in young girls, the percentage is increasing. The presence of endometriosis in young girls is increasing, and that also usually in the newly married couples. See, the newly married couples, they wait conception for some time due to certain reasons, their own personal reasons. They'll be waiting, and it gradually goes on to the presence of or the occurrence of endometriosis. And later, when they think of getting conceived, they come with infertility. So that's a commonly seen condition. That is when pregnancy is being evaded due to certain reasons. So in young girls also, we have to think of endometriosis. See, endometriosis means that is the presence of ectopic endometrium. That is, the normal site of endometrium is the intrauterine cavity. The inner lining layer of the uterus is the endometrium. And actually, the exact cause is not found, but endometrium is seen. It can be seen either in the myometrium. When it's seen in the myometrium, you call it as adenomyosis. It can be seen anywhere in the pelvic cavity. That is, in the ovaries. In the ovaries, when it comes, you call it as chocolate cyst of the ovary. Then it can occur in the pelvic cavity, and you call it as pelvic endometriosis. So like that, anywhere in the, then you have its occurrence in the uterosacral ligaments. So that is the endometriosis of the uterosacral ligaments. And here, in fertility, you come across this condition. The patient will be complaining of severe dyspareunia. So dyspareunia, when it's seen in the uterosacral ligaments, it can be seen in the rectal wall, on the bladder wall, etc. When the patient will be having severe ineffectual urging for stool or urine at the time of menstruation, that is related to menstruation, either during or at the close of menstruation, the patient will complain. So these symptoms you have to be aware of. There is an endometriosis. See, the endometriosis, it can be seen anywhere in the body. You get it in the lungs also. When it's seen in the lungs, it's manifested as pleural effusion. You get effusion in the lungs. Effusion, but the patient will not be having any previous respiratory complaints or anything, but during menstruation, the patient will be having this effusion. And wherever the endometriotic tissue is there, it responds to the hormones of the body. It is to whatever hormones the normal endometrium responds, to that this ectopic endometrium also responds. So because of that, see, it can occur in the subcutaneous tissue. See, some ladies will be complaining of patches on the skin, which gets, it occurs only at the time of menstruation. You get reddish patches, which becomes deeper in color, and gradually, as menstruation ceases, it fades away. But at the time of menstruation, it will be very tense and tender at the time. So that is nothing but subcutaneous endometriosis. So there also the endometriotic tissue responds to the hormonal influence. So you can see it in any part of the body, anywhere in the body, endometriosis can occur. So that you have to be aware of. That is, whenever a patient complains of an abnormal tenderness or redness or something anywhere, or just a growth-like structure somewhere which is red in consistency, definitely you have, it can appear in the vulva also, in the round ligaments, everywhere, anywhere it can appear. So when you come across such conditions, you have to ask the patient whether it has any relationship with menstruation. So if it's getting aggravated during menstruation, you have to your mind, it can be a case of endometriosis. So like that, when you think of this congestive dysmenorrhea, one condition is endometriosis. Usually in adenomyosis, you get this congestive, that is, in adenomyosis, the condition is the patient will be having a progressive menorrhagia and congestive dysmenorrhea. That is usually seen in ladies between the age of 35 and 40. In such ladies, when you get such a condition, that is a progressive, that is, it will be of a recent onset, because with each menstruation, the pain will be increasing. Along with that, the bleeding also will be increasing. The quantity of menorrhagia, the quantity of blood will be increasing during each menstruation. So very soon the patient will be approaching a doctor, because it's the the ages between 35 and 40. So the patient herself will be anxious about it. So very soon she'll be approaching a doctor. So you can see the complaint occurs, it will be of a recent onset. Definitely you can think of adenomyosis. And in the chocolate cyst of the ovaries, the patient will be having initially a one-sided pain. That is, the congestive dysmenorrhea will be there, but it will be either on the left iliac fossa or the right iliac fossa, on any one side. And gradually, the pain will be coming on both sides. And in pelvic endometriosis, the pain will be felt at the center, the hypogastrium. The pain will be present at the hypogastrium. And gradually, as the disease progresses, the patient will be having a constant pain in the lower abdomen. It is both in pelvic endometriosis as well as in ovarian endometriosis. In both these, the patient will be in the later period, she'll be having a constant pain in the lower abdomen. And that, see, usually when you take the usual investigation you do is a USG. See, in endometriosis, the thing is that in USG, if the ovaries are affected, you will be able to understand it. That will be you get the picture in the USG. Also in adenomyosis, you get the picture. That is, there'll be a heterogeneous endometrium, and you can think it's adenomyosis. Whereas if it's seen in the pelvic cavity, or if there are adhesions in the ovaries, in the uterus and all, there is the ovaries will get adheres to the uterus or to the pelvic fascias and all. There is a peculiarity of endometriosis, and the pain of endometriosis is very, very severe. See, usually it gets aggravated during menstruation, but as the condition gets aggravated, as the disease progresses, the patient will be having a constant pain in the lower abdomen, which gets aggravated during the time of menstruation. And the pain is very, very severe. Very severe means, see, it is said that the pain of cancer, a patient who gets pain in cancer, it is the same pain the patient feels. And when you analyze endometriosis, it has all the features of malignancy, but it's not a malignant condition. It's a benign condition, because it has a capacity to infiltrate the adjacent structure, which is a feature of malignancy. Then it causes adhesions. That's also a feature of malignancy, but still it's not considered as a malignant condition. It's a benign condition. Still all the features of malignancy are there. So the patient will be suffering much A person with endometriosis will be suffering too much with it. So the only way is that, see, the gold standard diagnosis of endometriosis is nothing but laparoscopical investigation. That is, by laparoscopy, you can just see the case, you can watch the condition with your eyes, or by a laparotomy, that is opening the abdomen. So these are said to be the gold standard diagnosis, because this pelvic endometriosis and all, it won't be understood in the USG also. Only in MRI, to a certain extent, you can diagnose the condition in MRI, not completely, but to a certain extent, you'll be able to diagnose endometriosis. So that is one of the faults where we fail, that is, we can't exactly diagnose the condition. But if the picture is that is this progressive congestive dysmenorrhea, severe pain will be there, and the nature of the disease, you can just confirm it will be a case of endometriosis. And if the ovaries are affected, definitely ovary is one of the frequent site where endometriosis is likely to occur. So since that is the most frequent site, ovaries can get affected. You can see small cyst in the ovaries. That is, you call it as chocolate cyst, because if you cut open the cyst, you get a there is, the blood will be an altered blood coming out of it. It will be having the color of chocolate. So you call it as chocolate cyst, because during each menstruation, the ovaries will be, that is the site of endometriosis. In the case of ovary, if a cyst has been formed, during each menstruation, the ovary will be increasing in size, because the menstrual changes will be occurring inside the cyst, and the blood will be getting, the menstrual blood will be getting collected. So each time, after each menstruation, the cyst will be increasing in size. Whereas here the prognosis is that when you give the homeopathic remedy, the prognosis is that after 2 or 3 months, you take a USD. If an ovarian cyst had been present, see, the size of the cyst should reduce. And the symptoms of the patient, the prognosis, that it's very clear. That is, when you give your first dose of medicine, the very next menstrual period cycle, the lady should have relief of pain as well as the bleeding. That should get reduced. That is the good prognosis. That is, with the first dose itself, the patient should get relief. So that is the better prognosis. Then you can just go on. And in all these conditions, say, you can say these are not acute conditions. There will be only acute manifestations. These are chronic conditions with acute manifestations. So in all these cases, you start with a low potency. A single dose is enough. Don't get scared about the disease condition. A single dose is enough. You just give it and you just watch the case, because it will be working. Case will be working with a single dose. Ask the patient to avoid all medicinal substances. That is, the medicated waters, hair oil, medicated hair oil, all this should be avoided. And also you have to instruct the patient to take a diet. That is a special diet, means you have to regulate your diet. That is in case of endometriosis as well as in fibroid. You can consider that it is due to the high level of estrogen, which seems to be the etiology of both these conditions. That is fibroid as well as endometriosis. So in both these conditions, you can ask the patient to avoid certain food items. Say those food items are, say, groundnut can be avoided. Then you can ask the patient to avoid this broiler chicken. Broiler chicken should be avoided, because that contains plenty of estrogen. Then the egg, there is a white egg which contains plenty of estrogen, that should be avoided. That is artificial estrogen. The food containing, or the food items that are likely to stimulate the production of estrogen. There is, in that, under that you have this green leafy vegetables. So that also should be avoided. Drumstick, that also stimulates. So that should be avoided. Of course, the patient can take it. That is, once in a month, the patient can take it. Not complete avoidance. The patient can take it once in a month. So, and also the fried items and all, ask the patient to avoid fried foods and all. That is, to reduce the level of cholesterol, and it's better to keep the patient healthy. So you can ask the patient to avoid those items and you give the medicine. So with that, the patient will be getting better. So the better prognosis is with the first dose, there should be relief. And usually when I give, I start with the 30th potency. See, these two are related, the guy and this fibroid and endometriosis. See, in fibroid, it's nothing but benign tumor occurring from the myometrium of the uterus. And that also See, the malignant tendency is very less in fibroid. It's a benign condition. The tendency for malignancy increases only when it persists after menopause. If a patient has persistence of fibroid even after menopause, the tendency for malignancy will be there, because, you know, as you all know, there'll be degenerative changes occurring in the fibroid. That is, when a fibroid persists, some changes are likely to occur. There is hyaline degeneration, cystic degeneration, and in pregnancy, you get a degeneration. That is, it becomes purple colored, red degeneration, you call that condition. During pregnancy, there is a lady who's having a fibroid. During pregnancy, changes are likely to occur. That is due to increased vascularity, get a purplish appearance, you call it as a red degeneration. Then you have during, after menopause, sarcomatous degeneration is likely. Sarcomatous degeneration is definitely a malignant degeneration. So this malignant degeneration can occur if the fibroid persists after menopause. So I think you should be cautious about it. And in fibroid also you have menorrhagia. And depending on the site of the fibroid, there can be either spasmodic dysmenorrhea or congestive dysmenorrhea. Anything can occur. Whereas if it's a subserous fibroid, there is a fibroid occurring on the outer surface of the uterus. And if it happens to be near the fundal portion of the uterus, there won't be any symptoms. No menstrual disturbance, nothing will be there. The fibroid is very free to grow up. It will grow into the abdominal cavity, and the patient will feel a discomfort only when it reaches the diaphragm. When it causes pressure against the diaphragm, the lady will be feeling a sort of discomfort. That is when she, after food, she'll be having a sort of suffocation. So that is the peculiarity. In a subserous fibroid over the fundus, it can become very large in size without any symptoms. Whereas if it's within the pelvic cavity, and it's likely to cause congestion in the pelvic cavity. If it's likely to cause congestion in the pelvic cavity, definitely the patient will be having a congestive dysmenorrhea. And the menstrual irregularities. See, in fibroid, all the types of menstrual irregularities can occur, right from menorrhagia. There is excessive bleeding. Metorrhagia can occur. There is intermenstrual bleeding. And intermenstrual bleeding means it can occur either associated with menstruation or independent of menstruation. Associated with menstruation means either at the onset of menstruation, the patient will be having a scanty discharge for a few days. Or at the end of menstruation, there will be a scanty discharge persisting for a few days. The bleeding stops, followed by scanty discharge. So it can occur like that, intermenstrual bleeding. Or in between two cycles, there will be a short 1 or 2 days of bleeding, scanty flow. So it can occur like that, or it can present as polymenorrhea or polymenorrhagia. Now, see, polymenorrhea means the cycle will get shortened. See, suppose a lady is having a 28-day cycle, that will get shortened to a 10-day cycle. So that means every 10 days, she'll be having her usual menstruation, 4 to 5 days flow. That is known as polymenorrhea. And if there is excessive bleeding along with that, you can call it as polymenorrhagia. And another name is epimenorrhea or epimenorrhagia. See, in fibroid, it can start as amenorrhea also, or scanty bleed, oligomenorrhea. Like that also it can present. That is, these presentations occur in subserous fibroids. So anyway, the bleeding will be there. There can be menstrual disturbances plus pain. See, the fibroid as such, it's a painless condition. Only these pains will be there, and fibroid becomes painful only if some changes occur, degenerative changes occur in the fibroid. So you can palpate per abdomen. If a fibroid is very large enough, you can palpate it per abdominally, and you'll be able to see it has a firm feel. You can feel the firm mass. It will be painless. Even though it becomes very large, it will be painless in consistency. But if degenerative changes occur, it becomes painful. Also in acute conditions, even torsion of the fibroid can occur, or rupture of the capsule when it becomes an acute condition. Severe pain occurs, acute pain occurs. So otherwise, when you palpate, there will be pain in degenerative conditions. See, there also we have medicines. And when you compare these two conditions, endometriosis and fibroid, see, the medicines usually given, see, how I prescribe is that I just take the case properly. See, don't get scared or attracted by the name or the diagnosis of the disease. You just take the case of the patient before. Because here, The detailed case taking is always important because these conditions, see, endometriosis also, even though there isn't a malignant tendency, see in a minute form, if it persists after menopause, a tendency is there for malignancy. Some changes can occur. So there also you have to be cautious. So whatever it be, we can prevent those conditions from going to malignancy with our homeopathic medicines. So in the case of fibroid also, you just start with the lowest potency. Just give a single dose. You just wait for 2 or 3 months. After that, if the time has come, you can give the next higher dose. Like that, you have to proceed. And in between, you ought to give the anti-miasmatic remedy because it will come to a standstill at a certain level. So there you'll be forced to give the anti-miasmatic remedy. So to give the anti-miasmatic remedy, you have to take the case in detail. Initially, so you have to go through the family history in detail, the disease conditions running in the family, which will point towards the miasm running in the family. So if malignancies are there or the psychotic conditions are there, definitely you can identify the miasm running in the family, and you have to, that is when it comes to a standstill, there is sometimes it happens that the symptoms are relieved, but the condition is not passing away. When you look, do the investigations, the fibroid will be there. It won't subside in size. Definitely, you give the anti-miasmatic remedy and then you proceed. And Medornum is one important anti-miasmatic remedy. And the importance of Medornum is that if there's a malignant tendency also, we can prevent it with Medornum. Medornum actually prevents the condition from going to malignancy. So Medornum is a very, very important remedy in the treatment of fibroid. Then Tuja as an antipsychotic you can give, but Medornum prevents it from going to malignancy. So you give the Medornum, and after the next 2 or 3 months, you can start from the 30th potency. And I'm insisting on these because, see, when a new growth occurs, in case of new growths, always it said you start with the low potency. The low potency works. So you start with the low potency. Then gradually you can go up. So directly, and in case of fibroid, endometriosis and all, another important thing is that suppose you're giving the 1M potency initially itself. That is before going to the 30 or 200 potency, if you start with the 1M potency, what happens is that, say suppose it happened to be the simillimum, there will be a relief of all the symptoms, but the condition will persist. The fibroid will remain as such. Right from the beginning, the patient will be having relief of all the symptoms, but the condition will persist. So that is one thing to encounter with. So always in the case of new growth, start with the low potency. Then you go higher when you can see that in the next USGs, the size will be getting reduced. So during this time, you just give only the placebos during the intervening period. And in between, if the patient gets any symptoms, any other research, any acute condition or something like that, you can just give a biochemic. Or else, if a bleeding has occurred, you can either give biochemic or some tinctures can be given at the time. Don't interfere with the remedy which you have given. So don't interfere with the action of that remedy. So for that, we can give a tincture, and that also not in large quantities. There is maximum 5 drops. Like that you can give. Or in divided dose form you can give. Even biochemics will stop the bleeding. So like that you can try. In between, if anything happens, always just watch the case. So that is the method, and the common remedies you get are, say, one is sepia, pulsatilla, matrimor, calcarea carb, calcarea floor. Salve is a very good remedy. Rustox is another very good remedy which you can give. Then sabina, silicone, Fraxinus americanus. See, Fraxinus americanus, see, we have a false belief that Fraxinus is the specific for fibroid. So it's never specific for fibroid. Also, Oromore natronatum. You just give plenty of Oromore natronatum to the patient. See, it will help only to increase the size of the fibroid. So don't give it like that. Of course, you can give Oromore natronatum. So Oromore natronatum is indicated when the patient goes almost towards the menopausal age, and when the tendencies, if the family background is there, the hereditary tendency is there for malignancy. definitely hormone natriuretic gets indicated. So in the menopausal period, you can go. Then fractionous can be given in case of bleeding. That is, if the fibroid is, if the lady is having excessive bleeding, fractionous gets indicated. Then thalassemia bursa, that's another medicine which can be given for bleeding. It can be given in the tincture form or in the 30th potency. If you are giving the 30th potency, just take one dose and give it in divided dose form. That is, in half a glass of water, you put one dose, stir it, and give every 1 hour. And as the condition subsides, every 2 hours you can increase the time interval. Like that you can give. Then millifolium is another remedy which you can give for bleeding conditions. That is in bleeding of fibroid or endometriosis, wherever in whichever condition it occurs, just to subside for the amelioration of the bleeding, you can give those remedies. Then Eustilago is another remedy for protracted bleeding. It is usually you get it in PCOD, protracted bleeding. In PCOD, there is continuous bleeding. The lady will be having amenorrhea phase, then the periods will be coming regularly. Then it will just disappear like that. The continuous bleeding will start without any stoppage. It will run for many months like that. Eustilago is one of the important remedies. Then the other remedies for PCOD bleeding are graphitis for protracted bleeding. Then pulsatilla, another remedy for protracted bleeding. It goes on like that. Then Bovista is another remedy. You can give it. So in PCOD, we'll just discuss about PCOD. See, PCOD, usually seen in young girls, it can be seen in any period of life. That is in an advanced lady coming to the 30s and all, you can see PCOD. See, in PCOD, you get multiple cystic formations in the ovaries. That is, it can be seen in the UST as a peripherally arranged cyst. That is, you call it the necklace pattern. That is the diagnostic feature of PCOD. Usually, both the ovaries will be affected, and then very rarely you can see single ovary, but gradually it will go to the other ovary, and that is a peculiarity of an ovarian condition. When one ovary is affected, gradually the other ovary will also be getting affected. So it can pass on like that. So both ovaries will be getting affected. In PCOD also it occurs like that. And the patient will be presenting with irregular periods. See, usually if the menstruation, it can occur even though the cycle is 28 days. See, in most of the ladies you get it as a 30-day cycle. So 5 days before and after you can consider as normal. From 30 days, 5 days before, after can be considered as normal. But in a girl who was having 28-day cycle or a 30-day cycle, if the cycle exceeds like that, coming to 35 days, you have to consider it as an irregular cycle. Whereas a lady who's having 35-day cycle right from menarche, you just consider it as a regular cycle. You needn't think that because right from menarche she's having it, she's not having any complaints. Only thing is every 35 days she's having it. Just consider it as normal. Whereas if a lady who's having a 28 or a 30-day cycle, if deviation occurs from it, you can consider it as an irregular cycle. So in PCOD, the cycle gets irregular. Sometimes there'll be only a few days difference. Sometimes only 1 month difference. Sometimes 2 months, 3 months. It can go to many months like that. Irregular, and there is periods of amenorrhea, long periods of amenorrhea. So in such conditions, see, by a USG, you can diagnose the condition. Just by a USG, you get the condition diagnosed. And in PCOD, the peculiarity is that, see, if the patient has come after allopathic management, that is hormone management. Allopathic management means in, in fibroid also, fibroid, endometriosis, PCOD, in all those conditions, the allopathic management is the hormone management. They just give hormones to subside that condition. So hormones are given. So when a patient comes to you for the first time, that is whether it be PCOD, whether it be fibroid or endometriosis, if the patient has come to you immediately after an allopathic management, the best remedy to start with is Phytolacca. So in some cases, the patient will be coming, they'll be bleeding, and the bleeding was stopped just by taking the allopathic hormones. And the patient has come to you in the time being, that is, they have stopped, the bleeding has stopped, she has come to you. Just see, if you stop the hormones, definitely the bleeding will occur. Don't worry, you start with Phytolacca 30. Just give Phytolacca 30 one dose. Definitely, you'll be able to clear off the bad effects of the hormones. Just give Phytolacca 30. The bad effects of the hormones can be cured by that. After that, you give the indicated remedy. You take the case in here also, take the case definitely. Take the case, the family history should be given due importance. The past history should be given due importance. So everything should be given due importance and you select the remedy. There is a single remedy. You just select the remedy and the remedy which you give, just give a single remedy. Don't interfere in between. Just wait. In PCOD, if you rush out with the medicines, you'll be spoiling the case. So don't rush out with the medicines. Just give a single remedy and you just wait. Wait for the periods to get regular and gradually you can see appearance of the periods. You wait for the next month. See, next month also you can see the periods will be getting much more regular. So just wait until it gets regular. So as long as the periods are appearing, just wait. If you just try to raise the potency or change the remedy, whatever you do, you'll be definitely spoiling the case. So in PCOD, always keep it in your mind. Don't repeat any medicines. Once the periods appear, don't repeat any medicines. Just wait. Wait and wait until it gets irregular. If it gets irregular, you just go through the case once again. If it happens to be the same remedy, just give the next higher potency, a single dose. Or if you want a change of remedy, you can just select the medicine and just give a single dose. Only like that you can cure the condition. You'll be getting a cure only with that. If you rush out with the medicines, you'll be spoiling the case. Similarly, in the case of fibroid and all. See, I have seen many people giving calcarea floor. See, calcarea floor is a very good remedy for fibroid. But if you repeat it, you'll be spoiling the case. Because in calcarea floor, in the keynote itself, you can see, don't repeat the remedy too often. It's definitely said, don't repeat the remedy. And when you go through the mathematical, see, you have to keep those rules and regulations in your mind. What all warnings are there? Just keep it in your mind. Don't try to overcome those warnings because you'll be putting the patient in danger. So don't, see, there are people who give calcarea carb regularly, the biochemic form. Calcarea carb regularly they'll be giving and they'll be spoiling the case. That is, the fibroid will increase in size, it will go to complications. That is, the degenerative changes and all will be occurring in the fibroid. So don't do that. Don't repeat any biochemic. Of course, Calimore is a very good remedy. Califos is another very good remedy, biochemic for fibroid. But don't repeat it. If at all you want to give it in at any time, just give a single dose of biochemic. Don't give the next dose also. Just a single dose of the biochemic is enough to give a cure. So just give it. That is to give a cure of an acute condition which rises in between. Don't repeat it. Just give a single dose and wait. Don't repeat, even if it be a biochemic also, don't repeat it. Don't give one pill daily also. It will be causing complications. Whereas the single dose, if you give, it has marked action. It gives you marked action in that case. So don't repeat it like that. Similarly, the tingers also. See, some people, they just go on Fraxinus americanus for fibroid. See, you're just actually spoiling the case. Don't give any tinctures in that manner. That is, don't ask the patient to take it continuously like that. If at all an abnormality, clear-cut indication occurs, just take it until that condition subsides. Don't repeat it like that. So just ask the patient to take it only for the time being. Then you stop that remedy. So always there is, whether it be fibroid, endometriosis, PCOD. See, PCOD, see, for fibroid and all, we can manage the condition. But in PCOD, see, if you lose the thread, it will be just going off like that. You won't be able to catch up with it after that. So don't repeat a second dose. Always give a single dose. And in between, if a fever, something and all occurs, you can give a biochemic to control it. Just give a biochemic. Then, see, you have the other conditions like PID, pelvic inflammatory disease. See, in pelvic inflammatory disease, it is the fallopian tubes and the endometrium, of course, it's affected, endometrium and the fallopian tubes, and gradually the ovaries also get inflamed, which you call as PID, pelvic inflammatory disease. And there the manifestation is the patient will be having menorrhagia, polymenorrhea. There is a classical picture. In some cases, there will be scanty menstruation. But there will be profuse vaginal discharge, and the discharge will be it can be very offensive, yellowish, like that, depends on the stage of the condition. So initially it will be whitish, mucoid, profuse discharge. It can be offensive, but when it becomes offensive, it will be changing the color, yellowish in consistency it becomes. So like that, along with that, the patient will be having a constant pain in the lower abdomen, backache, and sometimes there will be urinary symptoms also. It's not a necessity. There can be urinary symptoms also. So in these cases, see our common remedies that come. See, here you have to diagnose the condition first. See, the reason is, see, a patient can have a vaginal discharge due to a number of conditions. It can be just a vaginitis. It can be a vulvitis. It can be just the affections of the cervix alone, cervicitis, which can cause a discharge, or it can be a PID. So, besides this, say without any gynecological condition, if the patient is having a chronic constipation, that can increase the pelvic congestion and cause a vaginal discharge. See, the vaginal discharge we get in aesculus. There will not be any fault with the genital tract, female genital tract, but the loaded rectum can cause congestion to the pelvic cavity and cause vaginal discharge. That is, in aesculus you get such a condition, increased vaginal discharge. So if it be due to, so that what I'm specifying is that you have to diagnose the condition. Whenever a patient complains of vaginal discharge, ask if the patient is having itching, if there is itching, if the color, take the nature of the discharge, if it is whitish, yellowish, mucoid, whatever it is. So you have specific vaginitis conditions like moniliasis, trichomonas vaginalis and all. See, in specific vaginitis, what you get is that, so in moniliasis, of course, the lady will be having a thick white curd-like discharge. There'll be severe pruritus will be there. And when you examine the vagina, you can see there is whitish patches sticking onto the vagina. If you try to remove it, there'll be raw bleeding surfaces. So, and the whole vulva will be inflamed due to the intense scratching. So that is, you get in what you get in moniliasis. In trichomonas, of course, there will be severe pruritus. There will be a vaginal discharge that is yellowish or creamy discharge, and irritating discharge. Irritating, yellowish or creamy discharge will be there in trichomonas. So in these two specific vaginitis, if you just examine the discharge, if you take a smear from the posterior fornix and examine, you'll be able to identify the organisms. Then another specific vaginitis you get in chlamydial infection. See this PID, which I said, it is said to be an STD condition. It can be a gonococcal condition, it can be a tubercular condition, it can be a chlamydial condition. Any of these organisms can cause PID, or staphylococcus, staphylococcus, streptococci, E. coli, anything can cause PID. And only when these STD organisms are related, you call it as an STD. Otherwise, it's a normal PID, a non-STD condition. So if it happens to be a PID, you have to differentiate it from vaginitis or cervicitis. And the method how you can examine it is that, see, when a patient complains of vaginal discharge, you just palpate the patient. If there is tenderness in the hypogastrium, on examination, if there is tenderness in the hypogastrium, definitely it will be of a cervical origin or a uterine origin. Either cervix or the uterus will be affected. So that is the condition. Whereas if there is any tenderness in the hypogastrium, but the patient is having profuse discharge, something related to the vagina, it will be vaginitis or vulvitis. So that's how you can identify the condition. So when such a condition occurs, you differentiate the condition or try to diagnose the condition. And of course, in gynecology, you can do a PV examination. See, the PV examination, only thing, you should be proper with the method of examination. And also, you shouldn't introduce an organism from outside into the patient. That is, when you're doing the PV examination, you should maintain all hygienic procedures. That is, you should use a sterile gloved hand. And if you're introducing a speculum, that should be sterile. Any other instrument, if you're introducing, that should be sterile. So it should be a sterile method of examination. The patient should be laid on a clean and hygienic place, table, and you have to do the examinations. So by PV examination, you can. So in all cases, it's better you diagnose the condition and treat it. And here the medicines coming for PID. See, the common medicines are, one is sepia, then graphitis, salb is another medicine. Then you have natramor, medornum, calcarea carb. Say in fibroid, I think I didn't mention calcarea carb. See, calcarea carb, calcarea floor, calcarea iodide, all these are very good medicines for fibroid also. And when you're giving calcarea iodide, be cautious. It is very specific and it has a deep, and it's a very deep acting remedy in the case of fibroid. So just give minimum dose. If you're giving the 3x potency, just give it in the minimum form. Otherwise, there will be an aggravation of the condition. Then another important thing I want to reveal is that now when we are giving this salb in plenty of doses, see, all my fibroid cases, patients who are taking salb, they're getting an aggravation of the condition. See, the fibroid will increase in size definitely. If that is, if the patient, say, when I tell them to observe all the precautions, that is, don't take any medicated things and all, and if they take fibroid and this ASAL, definitely the fibroid will increase in size. Otherwise, if you don't ask them to, if you don't give any restrictions to the patient and give ASAL, definitely they will survive because there won't be any complications, because they'll be taking coffee, they'll be taking all the medicated waters and all the medicated oils and all. In such cases, the patient will not be affected adversely. Otherwise, the patient will be affected adversely if the patient follows all the restrictions and take ourselves. In many cases have come to me. During the lockdown period, they couldn't come to me. So by the time they had got ourselves, they had taken, and definitely after that, when you take the USG, the fibroid might have increased 2 or 3 fold times like that. So it's very difficult for me to treat those cases, because when you're treating fibroid itself, when you're giving ASAL, say suppose you have given ASAL and the patient is getting relief, and you just wait, don't repeat the second dose, just wait like that. Otherwise, what happens is that just wait for at least 3 months. Otherwise, what happens is that if you give a medicine, give ASAL or repeat on the higher potency before 3 months, definitely you can see the size of the fibroid will increase. It will increase in size definitely. Whereas if you don't give any remedies, even after 4 months, the size will be getting reduced. But in between, if you rush out with the remedy, the size will increase. So it's always seen. In my practice, I've always seen this. There are certain remedies, and such dangerous remedies. One is ASAL, then calcarea floor is another remedy, calcarea iodide is another remedy. So be cautious when you're giving these remedies for fibroid. That is, in whatever gynecological conditions you're giving, just be cautious about it. Then you have another condition, prolapse, uterine prolapse. Since the time has the time exceeded, just a few minutes.
Yeah, you can continue for a few minutes.
Okay, okay, thank you. Say in the case of prolapse, see, prolapse you can identify, you can diagnose the condition only by a PV examination. Only by PV, because when you take a USG also, in most of the cases, they don't mention the prolapsed condition. So, and also, you know, as you know, prolapse can be of the anterior vaginal wall, of the posterior vaginal wall, or of the uterus. In all these cases, the patient will be having a mass protruding through the vagina. Of course, it can be the bladder coming down, the bladder wall coming down, or it can be the uterus coming down. So you can differentiate it only by doing the PV examination. And if it is the anterior vaginal wall, if the upper part of the upper 2/3 of the anterior vaginal wall comes down, the bladder protrudes through that. And we call it as the cystocele. And if it is the lower 1/3 of the anterior vaginal wall coming down, the urethra comes down through it. You call it as the urethrocele. And in the case of the posterior wall, the lower 2/3 comes down. You call it as the rectocele, and the upper 1/3 it is the enterocele. And if the uterus is coming down, see, when the bladder comes down, see, just by exposing the vulva, you won't be able to say whether it is the bladder or the uterus that is coming down. Because when you see the bladder bulging out like a bulb, you'll be able to see it come bulging out like that. You'll be having an impression it is the cervix that's coming out. No, it won't be the cervix, it will be the bladder that's coming out. You just push up the protruded part, the prolapsed portion, and you'll be able to differentiate whether it is the uterus or the bladder that is coming out. And if it is the uterus, definitely you have the first degree, second degree, third degree, and the fourth degree is the procedentia, the whole of the uterus. And of course, we have definite medicines for all these conditions for this prolapse. And for prolapse, as you know, Sekti is one important medicine. Restox is another very important remedy. Then you have Helonius, Lilium tig, Alatris farnosa. A number of remedies are there. A number of remedies are there for prolapse. Anyway, even procedentia can be cured. That is usually seen in old ladies because they will not be prepared. That is, their health will not be sufficient enough to withstand an operative management. Definitely, you can treat those conditions with medicines alone. Just give the indicated remedy, and in youngsters or in middle-aged people, and ask the patient to do proper exercise, because one of the important factors, the excess abdominal fat can lead to prolapse. So ask the patient to reduce the abdominal fat. So ask the patient to do the exercise, avoid lifting weight, heavy things. Ask the patient not to lift up heavy things. Also, lifting small children also should be told to them, because some people, they say that they are not lifting anything, but they'll be carrying the child, a 2-year-old child like that. So that's a heavy weight, because when you think of carrying a child, you don't think that you are lifting the weight. So that you have to remind them. Don't lift up a child. So that should be specified. Also, when they are washing their clothes, don't lift up the clothes, very heavy clothes, and ask them not to lift up the heavy clothes. So that should be specified to them. And you give the remedies. And Restox, as you know, so immediately after labor, if a lady has prolapse, Restox is the first remedy, because the stress and strain of labor, the ligament strain, the stretching of the ligaments and all can lead to prolapse. So Restox is the first remedy there. And of course, all the other remedies are also indicated, but when it refers to the stress and strain of labor, Restox comes as the first remedy. So you can give it like that. So these are the remedies you can give. And say usually, even though these remedies are indicated in these conditions, don't try these one after the other. You take the case, and what is the remedy that points to that case, to that particular case, you just give that remedy. That is the remedy for that particular patient. Even though these remedies have indications, for each and every case, just give that remedy. So don't connect it with the diagnosis and the remedy. Just select it, that is, think about the etiology and then give the remedy. So can I stop the class?
Yes, madam, we can stop it, because we have a steering committee meeting immediately after this session, because our 300th day of our continuous Zoom meetings will be on 27th, which we need to decide how to celebrate that. So we have an important meeting today.
Okay. Then I thank everybody, especially Dr. Shaji Kudier, for inviting me to this session. Yesterday also, I came here because of my classmate also. We did our PG together. So not UG, I'm much older than him. My PG I did with him. So I thank everybody who patiently watched this class. And the organizers who gave me such an opportunity. I thank everybody, and I hope that you have benefited with this class.
Exactly.
Okay, thank you.
For giving out of thanks to
just a few raised hands, 1 minute each. Dr. Hubert and Dr. Sridhara Kurup, don't extend the question answer session. Just 1 minute only, please. Yeah. Please unmute, Dr. Hubert. Yes. Please unmute.
Thank you very much, madam. Can you hear me?
Yes.
Very wonderful class. Very wonderful class. But I want to ask you, for sister cell, what is your indication where it's fully
symptoms will be involuntary urination. That is when the patient coughs, sneezes, and all. There'll be involuntary urination. Sepia is one important remedy. Then you have natrum oris, spongia.
Fully prolapsed case. Now keeping with pessary. They done pessary for to manage it.
Those are not permanent cures. Pessary treatment are not at all cures for such prolapses. Only the homeopathic management is the best. Because in pessary, when you use it, it will cause compression of the site, and ulcer formations and all are likely if it persists, if you keep those pessaries for a long period of time. So the better management is also the patient will not be having any uneasiness if you give the homeopathic remedy. See, very soon, within days, the patient will be getting relieved in case of cystocytoma, because that involuntary urination will be very soon disappearing. Just give Sepia 30.
This is a third-degree prolapse. Third-degree prolapse with a rectocele.
Yeah, of course, you can manage it, whatever be the complication. If there is anterior vaginal wall, posterior vaginal wall, and uterine prolapse, you can manage it like this way. And only thing in aged ladies, and if you're having a procedentia or not, to ask the patient to push the uterus upwards, the prolapse part upwards, and ask the patient to wash the part, that is after urination, defecation, or ask the patient to wash the part with hydrastis tincture, not direct hydrastis tincture, that you ask the patient to take a mug of water, put 5 to 6 drops of the tincture in it, and then wash the part. So the hygiene should be managed, and the prolapse part should be pushed up, and the clothing should be maintained in that way. That is, tight undergarments can be used, or a pad can be kept.
Thank you. Thank you.
Prevent the part from coming down.
Thank you. Thank you.
Hello. Whether you can, or whether it is audible?
Yeah. Yes.
Yes, I have 2 questions only. I will finish at the earliest within 1 or 2 minutes. The first one is that what is the medicine for fungus? Nowadays, so many ladies are coming with fungal infections.
Yeah.
What is your opinion about fungus?
See, for
For
fungal
me, it is
infections,
difficult to treat.
yeah,
That's why I'm asking.
Asal is one very important remedy. Asal. Then Sepia is another remedy. Graphite is still another remedy. Sulfur, another remedy. Sornum, another remedy. You just give the remedy and ask the patient to wash the part. Say for fungal infection, ask the patient to wash the part with there is a homeopathic lotion, either hydrastis or it can be echinacea tincture. Anything can be used. That is, don't pour the medicine in plenty. Just 5 to 6 drops in a mug of water, lukewarm water, and ask the patient to apply. And in fungus conditions, it's better to ask the patient to wash the part and soak it dry with a clean cloth, sterile clean cloth. And then if to prevent the itching, ask the patient to apply calendula powder. It can be applied, calendula powder. And usually in our college, we used to give vaginal douche. But according to Hahnemann, vaginal douche is not a good method of management. Say for vaginal douche, we use hydrastis tincture. We have a douche apparatus and we just give a washout, and that will give an immediate relief for the itching of the vagina. So in our college, we use it. A vaginal douche is given. And then, or else if the patient doesn't want the douche, you can just provide it like that. That is, wash the part with hydrastis tincture, lotion of hydrastis, and then soak it dry. And if as long as moisture is there, there'll be severe itching. That's why I told you can use the calendula powder.
Okay. My second question is dyspareunia. How you manage dyspareunia? So many causes are many, but how you manage? Because most of the questions you are answered, but these questions I like to.
Yeah. Dyspareunia, there can be a pathology behind it, or just a functional condition it can be. See, pathology, as I told you, endometriosis is one condition, PID is another condition where dyspareunia occurs. The functional condition is it can be a vaginismus. Just a vaginismus can cause dyspareunia. For those conditions, Sepia is one very important remedy. Sepia is very good for dyspareunia. And if it happens to be a pathological condition, you have to treat that pathological condition. Whereas in functional conditions, you can give Sepia. Platina is another remedy for dyspareunia.
Oh, okay, thank you, madam. Very excellent answer, and your deliberations were extremely good. Thank you very much. Thank you, Shaji Kudiat and the.
Okay, sir. Dr. Josai, sir. Dr. Josai.
Okay, thank you very much.
Thank you, Dr. Josai.
Thank you, Geetha Jose, for your wonderful presentation.
Thank you, Jose.
Because after a long time, we are hearing such a presentation. In many homeopathic seminars and everywhere, what we hear is use of mother tinctures, use of many remedies, you repeating often. All these nonsenses are going on in a big way, and people are highlighting it and glorifying it, and we don't know what is the result. See,
I can't
actually,
go by any of those things.
yeah. So the main thing
is
is, if the these are the mistakes which most of the doctors commit, and that's one of the reasons why the percentage of success of such doctors are very less. Even what we see is, if a remedy helps, they keep on giving it repeatedly for a long time without switching on to the miasmatic remedy, which can give a clear-cut reduction of the cyst or a fibroid or something like that. So many people are forgetting the miasmatic aspect of the diseases. That's one of the most pitiful condition. Even though we study the chronic disease and everything, many people don't know when to switch over to the miasmatic remedy. That's very important.
Yeah,
And
remedies, it works wonders in our cases.
yeah. Actually, when I was in the college, I have seen some students giving these remedies, especially MD students who are giving, who had their thesis on rheumatoid arthritis and all. They keep on giving Rostox for some time. There is relief, symptomatic relief. But when they switch on to Medorinum or Thuja, they see a marvelous reduction in the RA factor, ASO, and everything. So these parts are yet to be highlighted in a proper way, actually. In many seminars, we don't hear this. That's a pitiful condition. And I think if people follow these 3-4 things, like seldom use mother tinctures, seldom repeat the remedy, give only single remedy, then go to the miasmatic remedy when the superficial symptoms are over. So these are things which can improve their practice and the percentage of success also. Okay, anyway, very good. I'm proud to be your classmate. Thank you.
Okay, thank you.
Dr. Bhadran, sir.
Thank you, sir, for the chance given me to comment in this issue. First of all, I extend my sincere thanks to Dr. Geetha Jose for her excellent presentation, especially to warn elders and youngsters for repetition of medicine, which has done so much harm to patients than for cure, especially for potencies, biochemics, and tinctures also. I'd like to know, I have a case of 1.5 years aged female patient. She has constant desire to masturbate, not by rubbing the thighs together, or when the parent carries the child, they'll try to rub the vulva against their body. And I have given him and caladium, and the case approached me only one month back, but still it doesn't get relieved. Can you suggest a medicine, madam?
What is the mind of the person, of the child?
She's social and smiling.
See, I think Staphysagria will do good if the child is highly irritable, stubborn, or else platina will work. Child is very...
Platina you tried.
Yeah, platina.
Let me see. I shall try Staphysagria.
Okay. See, it depends on the mind.
Thank you, madam.
Give importance to the mind of the patient also.
Okay, Dr. Manoj.
Of course.
Yes, madam. So it was wonderful presentation. I had a few, just few doubts. Like you said, even biochemic can be given in single dose.
Yeah.
May I know, like Califos?
Yeah.
Like in like PCOD, you are telling we can give as a single dose. So what are the indications? So when to give Califos? Yeah,
Califos, see, as I told, see, Pulsarla is said to be a uterine tonic. Just like that, among the biochemics, Califos is said to be a uterine tonic. See, such bleedings in PCODs and all, when bleedings are occurring like that continuously. See, if it is a scanty bleeding, that is not very profuse scanty bleeding, You can just control it with biochemic. Califos can be given. You can either give califos, that is depending on the case. Natromore can be given. If it's a natromore case, just give natromore. 6x can be given. Just a single dose can be. And if you want to repeat it, don't repeat it like that. Just give that single biochemic in a divided dose form. Single dose of biochemic in a divided dose form. Just dilute it in half a glass of water and give every 1 hour interval.
Okay. Similarly, even ferrophos is I tried it few places for the bleeding, like
that
bleeding.
can be given. That is if the patient is anemic also. And in all these cases which I mentioned, I forgot to mention one important thing, that is in fibroid, endometriosis and all, even though the bleeding stops, you have to check the HB of the patient throughout, because all these are antipsychotic conditions. Psychotic conditions, so whenever the patient is likely to go to anemia, even though the bleeding is not there. So always check the HB of the patient, because it happens that the patient will be getting cured, but the patient will fall with anemia. So always you have to check the HB of the patient. And
one more case.
Yeah.
One more case. I am treating the PCOD case. She's responding well in terms of regularizing her cycles because previously she was on hormone tablets. So after the which she has gained a lot of weight and she had some kind of side effects of that. Of course, she is recovered from that. It's been 1 year now. She's on our medicine. Only complaint is her size of the breast, or in general, she's not able to lose weight.
Yeah.
So this is her one of the most
in
bothering her
conditions. Always the best management is that you have to ask the patient to do daily exercise. Daily exercise should be done by the patient. Along with that, weight reduction. Weight reduction means you control the diet of the patient. It is excess of fat, fried foods, and as I said, the chicken, broiler chicken should be avoided. Eggs should be avoided. Then the sweet items like chocolate, sweets, bakery items, all those should be avoided by the patient. Ask the patient to take plenty of fruits and vegetables. That's the ideal way. The weight reduction will occur definitely. You have to keep the patient in proper diet and exercise.
Okay. Thank you.
Dr. Lokmani Gupta, please 1 minute only, please. Unmute from your side, yes.
Thank you, sir. A very nice educative session done by Dr. Geetha. I want to know one question. Ma'am, what about Coccus sativa and Protellus horridus in case of menorrhagias?
Pardon, I didn't hear your questions.
What about Protellus horridus and Coccus sativa in case of menorrhagias or uterine irritable bleedings? Please give your guidance about these two medicines also.
Coccus sativa. See, in Coccus sativa, the discharges are always stringy. So you get such conditions. That is in vaginal discharges, in bleeding also, stringy discharges occur. Bleeding will be stringy. The Coccus sativa, hydrast is another remedy, then calibic, another remedy. The second one I didn't hear, sir.
Protellus horridus.
Protellus horridus, of course. So yeah, that is for bleeding conditions you can give. That is to stop the bleeding. You can give it in divided dose form. Just a single dose, as I said, in divided dose form can be given to control the bleeding when it is of a dark colored nature.
In which condition? Whether fibroids, due to fibroids,
in fibroids as well as in all the other bleedings, you can give it.
Okay,
then
thank
the
you.
other remedies you can give is one is adrenaline in low form. 3x form you can give it. That is, but when you are giving adrenaline, you have to be cautious. That is, you have to check the BP of the patient, because the BP of the patient is likely to vary when you are giving adrenaline. It's likely to go high if you repeat it too frequently. So whenever you are repeating, it's better you give it in divided dose form, and every 4 hours you check the BP of the patient. Of course, it works very well. It reduces the BP and all. And always in bleeding cases, one of the important thing is the posture of the patient. See, during the bleeding times, you ask the patient to lie down. That is, even the patient takes rest by sitting also, the bleeding will not stop. Ask the patient to lie down. Lie down and take the medication. The bleeding will stop.
Thank you, ma'am. So nice of you.
Thank you. So it is time to wind up. As I mentioned, there is a steering committee meeting waiting just after this session. So I invite Dr. Zubaida Salam to come forward and say a vote of thanks. And I personally thank you, Dr. Geetha Jose, my classmate in my MD program, for having 2 continuous sessions with very short notice. I highly appreciate, and it is a spontaneous deliberation of your enormous knowledge and experience. We all are grateful to you and thank you. We expect to have more presentation from you, and thank you for this wonderful session. So Dr. Zubaida, please come forward and say a word of thanks.
Good evening.
Zubaida, can you raise your hand? Yeah.
Peace be upon you all. Thank you, Dr. Shaji, for inviting me for delivering a lot of thanks. And our today's speaker, Dr. Geetha Jose, is my classmate and also a good friend. And also we are colleague in Government Homeopathic Medical College, Kozhikode. And thank you, Dr. Geetha, for your very great presentation.
Thank you.
In between your busy schedule at the hospital and at your home, you have spent your time to share with us, means sharing your experiences, and even can say even you're stressing on the principles of homeopathy, what you have studied regarding the single medicine and the dosage, all this. It's a very nice and very great presentation. Thank you very much for this presentation. And another thing, since this is a platform of both eminent doctors, homeopathy doctors, and also ordinary people, I hope this section will be exposing the opportunity of homeopathic management in gynecological cases, and even for the local people also, because it's both the doctors and ordinary people are participating in this platform. So you are exposed the opportunity of homeopathic treatment in gynecology. Again, thank you. And another thing, I don't know, Dr. said sir is today in our group. It will be ungrateful if I don't say a word of gratitude to Dr. Sir. Our said sir is our teacher who had dedicated his life for homeopathy and for the IFPH, even in this busy schedule and during this, we think he's old, but he's mentally and physically he's younger than us, I believe. And may God bless him. And also I extend my sincere thanks to the leaders of IFPH for working hard to bring this homeopathic world under a single umbrella. So it's a great, it's a great work. I thank you, all of them. And my sincere thanks to all the participants who are present in today's session. And thank you all. Thank you.
Thank you, Zubaida.
Thank you, Dr. Geetha Jose and Dr. Zubaida Salam, for your deliberations. And it is time to wind up. So we see you tomorrow with another wonderful session. Tomorrow we have a special guest, Mohanji, who is a spiritual leader from India, internationally renowned leader. Will be coming to our forum, and our patron, Dr. C.J. Varghese, will be interviewing Mohanji with the topic Man Beyond Matter, the Man Beyond Matter. So I invite all of you for tomorrow's session, and we wind up today's session. Thank you all for those who participated today. See you again tomorrow, same time. And all the steering committee members are reminded to join the special link sent through the steering committee group, and those who are others with who are part of our organizing committee for the 300th day celebrations. With this, we wind up today's session. Thank you. Good night. See you again tomorrow. Bye-bye.